Hi, this is Dr. Brenda Nordstrom, and today we're going to talk a little bit about trauma-informed care. As we have already talked about human trafficking in general and a little bit about trauma, we're just going to do a brief review, but then we're going to spend most of the time talking about the key principles of trauma-informed approach and then analyze how you can use trauma-informed approach in your current practice. As I come from a nursing background, many of my examples, of course, are going to be healthcare specific. But if you are listening to this and you do not work in healthcare, hopefully you'll be able to at least pick up on the concept and translate that over into your specific discipline. So, what is trauma? There are three basic types. There's the physical trauma, and that is when you have a sudden or severe injury. So, think of car accident, an injury on the football field, something that happens to you physically. Then there's psychological trauma, and in the psychological realm, it can be something that happens one time that's extremely intense. It could be something that is reoccurring or very prolonged. And the harm is done on the emotional, psychosocial, as well as the spiritual level. And it can also be connected to physical trauma, but it can happen solely on a psychological level, but frequently there is a tie with physical as well. Now, with adverse childhood experiences, since 1998, when the first ACE study came out, we've been studying more and more about adverse childhood experiences and how that affects the body. What's different with adverse childhood experiences is that it's something that happens before the age of 18. It's also dose dependent. So it's not, it doesn't look at, like, say, rape or sexual abuse as being worse than having um, a parental separation or divorce. What adverse childhood experiences looks at is the number. So specific with ACEs, they're specifically looking at how many of these events happen before the age of 18 versus the intensity or the significance of the event. Now, when we have responses to the trauma, it is labeled many, many different things. There's childhood traumatic stress. There's very complex trauma or complex PTSD. Medical trauma is another big one. And toxic stress, that is basically toxic stress goes more along with the ACEs. It's something that happens over and over, and the stress of the situation is just becomes too much to bear or has a long lasting effect on the body. And then epigenetic changes, that's a topic that we don't have time to get into. But if you are interested in learning about the effects of trauma, especially how it changes the body on the genetic level and can be passed generation to generation, look up epigenetics. It's quite fascinating. So we have effects of trauma, like we've discussed before, and because of the effects on the brain and the changes that go along with the limbic system, it makes it very difficult to cope with normal everyday stress, whereas we might just have a bad day. somebody who's had a lot of trauma in their background because of that increase activity in the amygdala, all of a sudden now it's the end of the world. Um, and people with trauma, because they've been hurt and relationships have been dysfunctional in the past, they may not be able to trust people, have difficulty maintaining relationships. And of course, with that, changes to the limbic system in the of the brain, there's difficulty in managing those cognitive processes. So the hippocampus doesn't work as well, so memories, um, it becomes very difficult to remember things. And the problems with the hippocampus can actually manifest later in life. So it doesn't necessarily happen at the time of the trauma. It's something that occurs and gets worse with time. That prefrontal cortex, being able to pay attention, critical thinking, making decisions because of the slower development, the lack of circulation and activity, especially in childhood, can slow that area of the brain and make it more difficult. And basically, in the end, what all that means is there's difficulty with emotional regulations and difficulty then managing the behaviors. When you can't manage your emotions, it's hard to manage the behaviors. And then with lack, or I should say decreased ability in being able to make logical decisions, it can definitely lead to trouble. And again, that goes back to because of the behaviors and the emotions and difficulty making sense and making decisions makes maintaining a relationship very difficult. So this leads us to the trauma-informed approach or trauma-informed care. The purpose behind trauma-informed approach is that we want to go into it being very non-judgmental. We want to keep it very patient-centered. We want to make safety the center of everything. And the idea is to, treat the patient for whatever services they are there for, but to also educate and empower them. One thing I like in SAMHSA, they talk about, this quote is from SAMHSA, and they talk about the perspective from which trauma is addressed or how treatments are implemented contributes to the outcomes for the trauma survivor, the people receiving services, as well as the individuals staffing the systems. And I think this is so important because we look at trauma-informed approach as being for the patient, which it is, but it also helps those providing the services. And you'll see when we get done how utilizing a trauma-informed approach actually will help you as a caregiver in the long run. So the goal of trauma-informed care, trauma-informed approach, is to prevent the patient from feeling a lack of control, to prevent them from experiencing unexpected changes, because when you've suffered trauma, you like consistency, you like structure. Those unexpected things cause anxiety, so you don't want unexpected changes. And by preventing those unexpected changes, you prevent the patient from feeling threatened, from feeling attacked, being vulnerable. And those feelings in the end also cause patients to feel shame. So we want to make sure that we are protecting them from feelings of shame. So trauma-informed care is broken down into 6 key principles. We have safety, trustworthiness and transparency, empowerment and choice, peer support, collaboration and mutuality, and cultural competence. And we're going to look at each of those 6 key principles. The first is safety. Safety is kind of the core. We want to make sure our patients feel physical safety as well as emotional safety. Now, you're trying to think, why in the world would you not be physically safe inside a healthcare setting? Well, when somebody has been abused, let's say I'm going to do it from the aspect of a female who maybe has been raped or sex trafficked. They are now in a gown. Their clothing is all off. They just have this flimsy gown that's open in the back. They're sitting on a cot, stretcher, chair, whatever. And in walks a male healthcare professional. If that male is standing between the door and the patient, now as a female, I'm sitting there going, oh my gosh, what's he going to do? Is he going to hurt me? Is he going to expect me to do something? He's standing between me and the door. I can't get away. What happens if he starts to hurt me? Can I get out? And those thoughts just keep going through their mind over and over because the person who came in is now blocking the door. There is no physical escape. The same can be said if it's a female too. I just happen to use the male as an example. But when we come in, if we are standing over the patient, and they're standing between them and the door, all of a sudden that physical space doesn't feel safe anymore. In the ED, or even the OR, how often do we have our area is just separated by curtains? We have no idea what's on the other side of that curtain. Is our trafficker over there? Is somebody who knows our trafficker over there? Can they hear what I say? Oh my gosh, if I say the wrong thing, it's going to get back to my trafficker and I'm going to be in trouble. So again, that safe space isn't safe anymore. So we want to make sure that when we have conversations with them, that we sit down, we don't stand over top of them, we meet them eye to eye, make an actual connection, provide privacy whenever possible. We also want to make sure that we meet their basic needs. And in healthcare, that means taking care of whatever medical issue they've come to have treated. So if they come in and they have a broken bone or something like that, we determine they've been abused, whether it's intimate partner violence, trafficking, child abuse. The first thing we want to do is, oh my gosh, we got to take care of this abuse situation. Well, to them, taking care of that broken arm is the most important thing. They've been dealing with the abuse for a while. To them, that's not high on their priority list. The broken bone is. So make sure you're taking care of those basic needs. And if somebody chooses to go back, let's say you've got somebody over 18 and they choose to go back to their trafficking situation or their intimate partner violence, whatever, we make sure that you, if possible, you can sit down and work out a safety plan with them. Now, emotional safety is just as important as physical safety. And we provide that by being very consistent and very predictable. Those who have experienced trauma, they want to know what to expect from us. So make sure you introduce yourself, you explain what is going to be happening, and then follow through with that. Warm handoffs are huge. So if you are introducing them to somebody or they need to go to another unit, let's say you have a pregnant woman who comes into the emergency room and you determine that she is probably being trafficked, but she's a high-risk pregnancy now and she's being admitted. So instead of just doing a phone call report up to the OB, you've already started a relationship with the woman. So walk with her up to the OB. introduce her to the nurse that's going to be taking over in the OB. And if there's any information you need to share, make sure that the patient knows what that information is that you're going to be sharing, and if possible, maybe even be there when you share that information so they're not taken by surprise. But what that does is that passes on to the next person um, a little bit of trust, because remember, trust is very difficult for them. So if you've built a little bit of respect and relationship, then you are now using the warm handoff to pass some of that on to the next person, so they don't have to start at the starting line. You know, they've already been given a little bit um, extra respect and, you know, an extra leg up, I guess, in the situation. So with trustworthiness, again, recognizing that their trust has been violated. Do not expect people who have got a trauma background to just automatically look at you and think, oh my gosh, this is a nurse, this is a doctor. I must respect them. They have my best interest in mind. I trust them. That's a bunch of baloney. That's not going to happen. We have to earn their trust. Part of doing that is having very clear and consistent policies and appropriate boundaries. Let them know right off the bat, this is acceptable, this is not acceptable. If they are raiding the utility room, you know, snatching up all of the, you know, the drinks and the juices, or they've got kids and family members coming up all over the place and they're just being very loud. You know, you have to be very clear with them. All right, these are the expectations. You can have, you know, one or two, or you and your significant other can each have a drink out of the utility room, but other than that, nobody else can. That's just the way the rules work here. And make sure that every shift, every nurse, every caregiver follows the same rules, because as soon as one person um, veers away from those boundaries, then you've lost everything and they will go back to manipulating. It's also very important that you explain what's going to happen. So don't touch the patient without their consent. Now, there's a difference between consent and assent. When we as nurses we got our stethoscope and our blood pressure and everything, and we walk in, and it's not uncommon to say, okay, I'm going to take your vital signs, and we put the stethoscope on them and we wrap the blood pressure cuff around them. Okay, that's assent. They are going along with what you're saying and doing because they feel they have no other choice. Instead, you know, I'd really like to get your vital signs now. Is that okay? And actually get their permission. I try to really, even with my dementia patients, I work in hospice care. So I make sure that even with my little dementia ladies, I show them my stethoscope and I specifically ask if I can listen to them. Most of the time they say yes. You can get yourself in trouble though when they refuse and you're like, oh, well, now what am I going to do? So you do have to kind of work around that a little bit. Maybe say, okay, well, I understand you don't want to have your blood pressure done now. How about I go do another patient and I can come back in 10 minutes or I can come back in 20 minutes? Which would you prefer? So then they still have a choice. But still make sure you get consent. Empowering. As healthcare providers, it's really easy for us to have that, um, you know, we just come across very confident and we're the expert. We know what we are doing, and so therefore you should follow our suggestions. And we really want to minimize that and make this more of a partnership. Find out what their strengths are, and yes, that takes a little bit of getting to know the patient, but you know what have they done? maybe, complement their personality. If they are choosing to leave their trafficker, or they're ready to make a stand, just say, hey, what you're doing is very tough, and I get that, and I know you're scared, but man, you're strong. You walked in here and you got some help. So just, focus on the things that they are doing well. And when it comes to patient choice, that means sitting down and actually setting goals together, letting them know the risks, the benefits, the pros, the cons, and help them see the full picture, but let them make the decisions whenever possible. They need to know what their rights are, but they also need to know what their responsibilities are. Now, when it comes to telling their story, actually talk to them and say, okay, I know repeating bad things that have happened to us is kind of tough. So, if you would like, I can share your story with the next shift. Is that okay? Do you want me to share that your history with them in the hall? Do you want me to share it with you sitting right here? But just ask them what their preferences are. Peer support. This would be outside of the hospital setting, but it is possible to find peer advocates to help them walk through the process. In rape cases, sometimes they will have peer advocates come in and actually be with a rape victim and help them walk through the healthcare process, with the rape kit and whatnot. But you have to make sure that any peers that are involved means they have to be through a certain level of healing. It is not uncommon um, in human trafficking when you work with survivors that some survivors, they get passionate, they want to help other people, but they haven't healed enough themselves. And I have worked with several survivors, and there have been a couple where I've thought that they were in a good stage of healing and come to find out they weren't. So you really have to be careful. But if there's peer support groups, but having somebody who's been there, done that kind of thing can just help get through tough situations, especially in the healthcare setting. Now, when I talk about stages of healing, there is a survivor that I do work with. Her name is Ruth Rondon, and she came up with the 4 stages of healing. Now, and she's very clear, this is specific for sex trafficking, but I think it does work in other areas as well. But she talks about how, number one, you're the victim, you feel like an outcast, you're still going through the trauma, and basically you're just surviving. That's it, you're just surviving. Once you actually ask for help and you're no longer being victimized, you become a survivor, but you're still just surviving. The next step is the thriver. That means you are starting to work, you're contributing to society, you're starting to plan for the future. Now, the 4th stage is that victor leader stage. That means they've processed their traumas, they're learning to understand the effects of everything that has happened, and they've begun accepting themselves for who they are, wounds and all. Now, the next is collaboration. And this means that you have very open, respectful communication. This is where your therapeutic and motivational interviewing comes in. So make sure you have those nice open questions. You make sure you respond back to them, let them know you're listening. Um, and with collaboration, you want to use descriptive terms. Um, and these take place more behind the scenes. Too often, nurses and others who provide services are like, oh, they are so manipulative, they are attention seeking, and my favorite, drug seeking. I hate that one. um, Instead of, and this just takes time yourself to watch what words you use, but instead of saying, oh, room 12, they are really attention seeking. Instead, saying, you know what, they're having a hard time getting their needs met. And so I know they're a little bit manipulative, but da da da, and then you can work, when you give report. But this is more of a personal thing where you just watch how you are referring to people. With cultural, um, a lot of this has to do with assessing your own judgments and your own biases. The more we look at ourselves, it's amazing how much we find buried in there. I like to tell nursing students to take all those judgments and those biases, pack them up in a little suitcase, and leave them on the front step. Don't take them into your patient's room. Um, and that's easier said than done, but with practice. We need to also look at the patient's culture, and I'm not just talking racial or ethnic culture. There are cultures, there's like if you live in a rural area, your culture is different than if you work in an urban area or live in an urban area. Poverty versus affluence, all of those have different, traditions and body languages and things like that. So make sure you identify those differences and understand where people are coming from. Now, those culture influences, um, they influence how we respond to trauma. So those from, say, poverty, maybe I think tend to be a little bit more, emotional about it, whereas those with affluence tend to be very um, tight and closed mouth because it's not acceptable to talk about those things in certain social circles. So, and also like a Hispanic versus, oh, somebody from, let's say Africa or Canada, England. Everybody has their different culture and they respond differently. If somebody, though, speaks another language, please, please, please make sure you use medical interpreters. Do not use family members. I was doing a training one time and I talked about this, and a couple of nurses were like, oh, remember we had that Middle Eastern woman in, and there was two men that were always in their room and they did all the interpreting for her. And it's like she was probably being trafficked when we look back at it. So use medical interpreters and don't assume that somebody is literate. Use graphs and visuals whenever possible. So to kind of wrap things up, some things to keep in mind is don't take strong reactions personally. People who have suffered trauma, again, emotional dysregulation, they're going to react sometimes very strongly, and it is not you. And it's amazing to me how freeing that has been for me as I internalize this, that when people get very upset, I'm able to tell myself, you know what? It's not me. I don't have to take that personally. Watch people for that appearance of being overwhelmed. Um, if they need to, allow them to have breaks. So if they start to act like they're being disconnected or emotionally shut down, that may mean they need a break. Because of the problems with the hippocampus, realize that changes in memory isn't necessarily storytelling. They're not lying to you, they just might not remember. And self soothing materials, I know those fidget spinners are, those were a fad back in the day, but whether it's Play-Doh, silly putty, pencil and paper to doodle, whatever it is that they like to do, allow them to have something to soothe themselves. Um, because those who have been trafficked, if they were trafficked young, developmentally, they may be more in the concrete stage and haven't really made it to the abstract yet. So break things down very concretely and very specifically. Focus on those facts and not so much on emotions. Again, because trust has to be earned, realize that them not trusting you is nothing against you personally. And because they don't trust you, they're not necessarily going to want to reach out to you. So you try to reach out to them. Meet them where they are in life. Whatever you think is a realistic expectation, depending on the severity of their trauma and their background, you want to make sure to avoid those unrealistic expectations. Um, and because trauma does have physical uh, effects, there are a lot of somatic symptoms that come along with trauma, and these somatic symptoms are real. They're very distressing. So don't um, just dismiss those complaints. If nothing else, just assure them that you're gonna, keep trying to figure out what's going on. And again, those, the headaches, the backaches, the stomach issues, that's extreme emotional stress. And the more stressed they are, the worse those physical symptoms get. And that is it. That is trauma-informed care in a nutshell. I hope you found it helpful. And if at all possible in the future, please either look into trauma-informed care and educate yourself or take a course that's being offered. All right, thank you very much, and we'll see you next time.